So it's my pleasure to introduce the next speaker. It's going to be Dr. Bill Berrigan, and he just joined our practice just this year. He trained in Georgetown for his physical medicine and rehabilitation medicine residency, and he did a fellowship out at Emory. So his special interests are ultrasound as well as orthobiologics, but obviously he knows a lot about the spine. So I'm going to turn it over to him and the team, and he's going to show you how he examines the back.
Thanks, Anthony. Appreciate it. So I like to think of the back exam in a stepwise manner, just kind of like any other joint that we're examining or any other musculoskeletal exam we're going to do. So I'll start with inspection, and then we'll go to palpation. Then I'll think about range of motion. So those are the three basics that we look at. Then I go to the two S's. So that'll be strength and sensation. We'll go through that. And then after that, there's some special tests that we'll talk about. So first, we'll start with inspection. So I'll take a look at the patient or the athlete. I'll have them face the other way, and then I'll take a look at their spine. So first, I'll just lift up the shirt in that area just to take a look at their back. And the first thing that I'm looking for is there any curvature within the spine? So you can see here that his back is pretty straight. Now, what I'm looking for is any scoliosis, so curvature in this area, any change in lordosis, so if there's excessive bend or excessive bend the other way, and then if there's any rashes or any erythema or anything within the area. The next step that I'll do is palpation. So what I'm going to do is palpate the spinous processes. So I'm going to go down the midline of the back and just press in different areas. And all I'm looking for is specific tenderness within the spine. You can also assess for any sort of step off. So you want to make sure that they're all aligned. And if you feel a step off, that might be significant for any sort of bony abnormality. After that, I'll palpate the posterior superior iliac spine. Now these are the dimples in the back. So dimples are down here. You just press right in that area. And when you press at the posterior superior iliac spine, this is where your SI joints are. So you palpate in that area for any tenderness to palpation, and then you'll look at the surrounding back as well. Then I'll go to the paraspinal muscles, and I'll just see if there's any spasming or if there's any tenderness to any of the paraspinals that Dr. Wingfield had talked about. So after palpation, you can go ahead and put the shirt down, and I'm going to look for range of motion. So the first range of motion exercise that I do is I have the patient go into flexion. Again, go ahead and bend over and touch your toes. And he's actually decently flexible. Well done. So normal flexion is about 60 degrees of lumbar spine. And what I'm looking for is decreased flexion, extensive flexion, but realistically, if they have any sort of pain when they do that movement. So if there's any pain when they go into flexion, you start to think of discogenic causes, so disc-related pain. Now, then I'll have them go into extension. So I'll have you extend backwards as far as you can, and then come back forwards. So normal is around like 15 to 25 degrees of extension. If you have any pain with extension, then I'm starting to think that it's more of a joint-related problem, so those facet joints that Dr. Wingfield had discussed. And then I'll have them go side to side. So go ahead and bend to this side, and then go to the other side. So normal for this is about 25 degrees. Well, what I'm looking for specifically is if I lean to one side and that alleviates some of his symptoms, what's going on is that you're actually opening up some of the joints where the nerve comes out. So if I bring out here and he has a pinched nerve on that right side, most of the time, this is actually going to improve the pain within the area because you're opening up what's called the neuroforamen, or where that nerve exits. Now, this works the other way too. So if I go to the right side, and again, he has a pinched nerve on that right side, this can exacerbate his symptoms. So I look for that when he does the lateral bend. So you can come right back up. Okay. And then while they're standing, I'll also do an exam maneuver called facet loading. Now, this is just an expansion of the extension exam that we had done before. So I'm going to take Daniel back here, an extension. I'm going to rotate his spine just like this. And then I'll rotate it the other way. So what you're doing is you're applying a load to that back. And so any pain with this is more significant for a facet-mediated pain, or pain within the joints within the back. So finally, at this point, now that I have him standing, I'm going to think of a couple other things that he could do. One is I'll have him walk on his heels. Then you can just walk on your heels forward, and you can relax. And then I'll have you come back towards me, walking on your toes. Great. So what we're assessing here is any weakness with dorsiflexion, so when the ankle goes up, and also with plantar flexion when he's flexing that ankle on the toes. This is a great way to pick up any subtle weakness that you might find. But we'll go through what we're looking specifically for with strength and weakness in a second. So at this point, I'll have Daniel go ahead and sit down on the table. Yeah, go ahead and sit over on this way. So we've done inspection, we've done palpation, and we've done range of motion. So the next thing we look at is strength. And when we're doing strength, we really want to think about each level of the spine. So there's L1 through L5 in the lumbar spine, and then there's S1 nerve root as well. So we're really thinking about how we can test each nerve at different levels. So what I'll first do is I'll test hip flexion. So I'll have Daniel bring his knee up towards his chest, and I'll apply resistance. And I'll do it to the other side to test to see if there's any asymmetry. Now with this, we're looking at the L2 nerve root. So if there's any weakness in this area, we're thinking that there could be compression too. Next, I'll do L3 and a bit of L4. Now this is any sort of knee extension. So what I'm going to have is Daniel go ahead and kick out nice and strong. Perfect. And I'll have him kick out on the other side. And again, we're testing for any asymmetry. Now I'll have you go ahead and take off your shoes. So we've done L2, we've done L3 with that knee extension. Now we'll go to L4. So for L4, I'll have you dorsiflex the ankles. So I'll bring the ankles up and I'll press against resistance. And I'll press against resistance. So this is the great way to test L4. And as you can see, this is also similar to the walking that he'd done before when he was walking on his heels. So you can combine those two to really think, is there any sort of pinched nerve at that L4 level? For L5, it's really interesting because it's just the big toe. So I'll have him extend his big toe and I'll just press down on it. So we're testing the extensor hallucis longus, and we'll test it on this side as well. So it's symmetrical, and this is subtle, so it's tough to pick up sometimes. But it's really the only one that you test for that L5. S1 is I'll have you plantar flex against resistance and plantar flex against resistance. Now it's tough, especially if you get some of these big athletes or stronger individuals to really tease out any subtle weakness within this plantar flexion or the S1 nerve root. So that's why I had him walk on his toes initially, because then you can see how high the ankle goes up. Just test for any sort of subtle weakness in that S1 level. So we've done inspection, we've done palpation, we've done range of motion, strength. So what's next is the sensory exam. So we're thinking about it the exact same way. We're going to go L2 through S1. So to test sensation in the L2 level, you go up to the medial aspect of the thigh. So all I do is just sensation to light touch in both areas. And I ask it to feel the same from side to side. That feels the same side to side. Good. So that was L2. L3 is at the medial portion of the knee. So I'll test sensation here and then here to light touch, looking for the same sensation from side to side. Now we go down to L4. So we're traveling down the leg. And I'll look at the medial malleolus, so that medial portion of the ankle. And I'll do some sensation in this area as well, seeing if it's symmetric. L5 is next, and L5 is right next to that big toe, just like you were testing for strength. And so I'll do sensation right in that first dorsal web space, testing symmetrically. Finally, there's S1, and S1 is going to be on the outside of the foot. So I'll test right here on that lateral side of the foot, sensation from side to side. And that is your sensory exam. So all that is left for the back is to do any sort of nerve tension signs. So tests for lumbar radiculopathy or that pinched nerve. So what I'm going to have you do is slump forward. So I'm going to have you slump just like this, and I'm going to lift this leg up. And if there's any sensation of radiating symptoms down the leg, then that is a positive sign for what's called a slump test. And if you're not getting anything at this level, you could dorsiflex them slightly, and that provides a higher sensitivity to look for any sort of neural tension signs. And relax. Good. So finally, after all of that, we can test for reflexes. Well, so I'll get this handy reflex hammer, and then I'll palpate the patella tendon. So this is your L3-4 level. And so just like that, we do the reflex. Great reflex. And then we'll test side to side. Then I'll do S1, which is the ankle reflex, the Achilles. And just a slight tap right on that Achilles tendon. So that's your S1. And then there's one other reflex that we tend to forget about. It's called the hamstring reflex, which tests the L5 level. So when I look at this, I'm going to palpate the hamstring on the inner portion of that thigh. And then all I'm going to do is just hit within that area. And what we're looking for is any hyperreflexia or hyporeflexia within the region. And if we forget about that hamstring reflex, we're really missing L5, which is one of the common places of compression of the nerve. So we always want to try to remember that L5 level. So that is the gist of the back exam. Now, occasionally, it's tough to tease out if it's coming from the back or if actually coming from the SI joint, that sacroiliac joint. And a couple of ways that I test that is, one is we look at the posterior superior iliac spine, which I had done previously, and we palpate at that level. If there's any tenderness at that level, then that could be significant for SI joint type pain. So after that, I'll have Dan go ahead and lay down on his back. Okay, so I'm going to repeat some of these maneuvers for the sacroiliac joint and how to tease that out. So the first one is called the thigh thrust maneuver, where I bring into hip flexion to about 90 degrees. And all I do is apply a posterior force to that hip. And if this causes pain within the back, so in this area, right in the SI joint, then that's positive. From this position, I could bring him into a figure 4 area here. This is called the Faber exam, which is a flexion, abduction, and external rotation, which just describes that figure 4 position. So if I press down on his knee, and that causes pain in that back area towards the sacroiliac joint, then that is a positive exam. The next one, I'll have you scoot towards me, and I'll again bring his knee into flexion. So I'll bring your right knee this time into flexion. And now this time I'll go beyond 90 degrees. Now what I want to do then with his left knee is extend it off the table. This is called a Gainsland's maneuver. So if I bring him into flexion and press down on that other side, you're really stressing that SI joint. So that would be a third maneuver. Next, I'll have you lay on your right side. This one is very simple. It's called the compression test. So all I do is just press down right on the side of his hip a few times. 1, 2, 3. And if there's any pain with compression, then that's positive. And then the last one is I'll have him lay on his stomach. And again, we just look at the SI joint of that posterior superior iliac spine, and then you press down and compress. 1, 2, 3. And see if that produces any pain within that SI joint. And then you can sit up. So that would conclude the test that I would do for the back and also for the sacroiliac joint. Now it's important to know that if you just do one test for the SI joint or for the sacroiliac joint, then that's not very sensitive. So it's really a combination of these tests that can help you tease that out. And if you have any questions, I'm happy to answer or repeat some of the exam maneuvers. So the question is, how can we differentiate between a piriformis syndrome and a lumbar radiculopathy? So I see these both in my clinic, but the majority of the time, common things being common, it is a lumbar radiculopathy rather than a piriformis syndrome. So I always think about that first. But when I'm looking for a lumbar radiculopathy, what I'll do is I'll have him lay down on his back and do that straight leg raise. So all I have to do is lift that leg up, and then you could even press down on the ankle. And that'll produce some symptoms down the leg. That's more sensitive for a lumbar radiculopathy, or that slump test that I had showed before. Now for piriformis syndrome, it's a little bit tougher. There's a piriformis stretch test, which is the exact same as Faber, where we bring him into flexion, abduction, and external rotation. Now this stretches that piriformis muscle. So if they're having pain specifically in that muscle, then that's more sensitive for a piriformis syndrome than if they're having pain more in the back, that's more thinking about the SI joint. So I'll have you lay down on your stomach and I'll palpate the piriformis. So just so you guys know where it is, what I do is I palpate the posterior superior iliac spine first and slowly move my fingers down, about 4 finger breaths. And I'll just press right in that area. And if there's tenderness in the piriformis, then that is also another good test for piriformis syndrome. So you look for the two combined. You look for the flexion, abduction, external rotation, producing pain right in the piriformis. And then you also look for that tenderness, the palpation within the piriformis. So the question is to go over the test for a pars stress fracture. So Daniel, I'm going to have you go ahead and stand up, please. And just like a facet load that I had shown before, it's pretty much the same thing, but with you have them lift up one leg. So go ahead and face this way. And what I'll have you do is lift up your right leg. And then I'm going to bring him back just like this. And if that reproduces any pain, then that's significant for or concerning for a pars stress reaction. And this is called the Stork test. And you could do it from side to side. And so if I have him take the left side up too, and then I have him bend backwards, and they get pain with within this area of the spine, and that's a positive Stork test. So the question is, looking at the Faber test, how can you differentiate between the SI joint and the piriformis? So realistically, it's the same test. So you're bringing them into a figure 4 position, and then you're pressing down on the knee. Now, if the patient has pain within the posterior aspect of the glutes near the area of the piriformis, then that's more significant for a piriformis syndrome, especially if it reproduces any symptoms down the leg. If they have symptoms that are more in the back area, then that is significant for pain within the SI joint. Also, it helps to do these other maneuvers for the SI joint to see if those are provocative or not, because it's always a combination of maneuvers for the SI joint, whereas the piriformis, there's only a couple tests for that. So the question is to talk about SI joint pain management. So there's 2 types of SI joints. There's the SI joint that is very hypermobile, and then there's the SI joint that is hypomobile. And you treat them kind of differently. So we see the hypermobile SI joints more in females, especially after pregnancy. And we see the hypomobile joints more in males, although you can see it in both.
So with a hypomobile SI joint, where it's kind of locked up, or they'll describe it as a locked up sensation, there's different maneuvers within physical therapy that they could work on to unlock that joint. So physical therapy is always my first step. If it's more of the hypermobile joint, then they work more on strengthening everything around that SI joint to help kind of tighten it up. And again, that's physical therapy. And the physical therapists are great at kind of recognizing which type it is. Now, if they don't respond to physical therapy, then you can consider different types of injections within the joint, whether that's corticosteroid or if there's like PRP or prolotherapy. There are different treatments for the sacroiliac joint, but it would always start with physical therapy and then consider an injection into the joint. The question was tips on eliciting the Achilles reflex and also Waddell's tests. So the Achilles reflex, what I always do, first of all, I have them seated, and then I'll palpate. You want, yeah, go. So I'll have them seated in this position, and then what I like to do is dorsiflex them slightly. I'll palpate the Achilles, and then I go with the reflex hammer at the mid portion of the Achilles and just go straight at it. And so what we're looking for is plantar flexion of that of the ankle. Now, it's important to know that within our older patients, there's the S1 reflex, or that Achilles reflex, is not always present. So don't be too concerned in your older individuals if you're not really able to elicit that Achilles or S1 type reflex. The other question was Waddell's signs. So Waddell's signs are more of to elicit if somebody is faking low back pain, and there's a variety of criteria. But more often than not, what you're doing is the exact exam maneuvers that we just did, but seeing if they're pointing or describing a different area of pain. For example, if I do the slump test and I have you go down like this, and they're like, oh yeah, that really hurts in the back, it hurts right here, I feel it over here. Well, then obviously that's not what you're looking for. You're looking for pain that goes down the leg. And so when something is discordant with what you're expecting to see, then those, that's kind of signs of Waddell's. But there's a specific criteria for each one, but that's kind of the basics of it. So are there any other tests for piriformis? So those are the two that I use most commonly, is the piriformis stretch test and the palpation, tenderness to palpation of the piriformis muscle. There are not a whole lot of other good tests for the piriformis. There is one where you can, let me have you, have you lay down on your stomach. And then I'll bring the knee into flexion. And what I'll have them do is resist against my pushing of their foot. So this is resisted external rotation. And then I'll have them do resisted internal rotation as well. And so this is internal external rotation of the hip. Now, if one of those provokes symptoms within that piriformis muscle, this is also another test that you could try for piriformis syndrome. But like I said, the most sensitive ones that I like to test are that tenderness to palpation and that piriformis stretch test.